We're probably the world's leading center for cancer genomics, having sequenced the first cancer genome in the world in 2008, and that's been really the start of personalized medicine in the world. The basic research that we do now is the fuel that lights the fire of clinical research in a year or two. And so we have a large number of basic science investigators that are doing very fundamental things. We've been very interested in the fundamental aspects of graft versus host disease, and I think we've been the center that started to really look at a pathway called JAK signaling pathway for mitigation or treatment of graft versus host disease. Probably one of the most frequently used drugs for the treatment of graft versus host disease are JAK inhibitors, and I think it's based on our basic science laboratory discoveries here.
So one rule that John DiPerzio and I have had for the essence of the studies that have come from this group is that we start at the bedside. We let the patients define the rules. That is an essential feature of all of our work. We do not model things based usually on hypothesis testing in the laboratory, trying to take it towards the patients. We try to make the observations using patient material first. For a long time, we've been interested in the molecular underpinnings of acute myeloid leukemia and its related disease, Myelodysplastic Syndromes. When the human genome was sequenced back around 2000, we were very interested in utilizing that information to really begin to better understand the mutations that caused AML. The toolbox that we have to work with this kind of data is getting better and better. Integrating all that material together in a clinically useful way is very important. It's also important to do it not ad hoc but prospectively, using well-designed clinical trials that are designed to determine whether these testing ideas that we're working on now really make a difference in terms of how the patients do. We have to not just use the data because it's there, but we have to use it in a way that is instructive, informative, that clearly, by the best scientific criteria, tell us that we're making a difference in patients' lives, improving their outcomes because of the testing that we're doing.
Well, one of the things that I've always liked about Washington University is the close interaction between the basic scientists, the clinicians, and the patients. So what's really heartwarming as a scientist is to see the bench to bedside. And so we do a really nice job of facilitating interaction between our basic scientists and our clinicians. And I think it really helps us translate this into better treatment. One of the things I do is I'm the head of the SPORE in Leukemia program. Washington University has two very large multi-center grants. One is the genomics of AML PPG, that's led by Tim Lay, and then the SPORE in Leukemia. So together these two large grants bring about $26 million of funding in from the NCI and involve about 30 faculty. Todd Feniger here is leading an effort to develop a new type of immunotherapy using natural killer cells. It's early days, but there's some very exciting results. And so this is potentially something that he's used right now mostly for leukemia, but he has plans to use this in lymphoma, myeloma, and who knows, perhaps other solid tumors too.
I'm more on the clinical and translational side of research and mainly focused on cellular therapies. Cellular therapy mainly using cells to treat cancer or cure cancers. That include chimeric antigen receptor T-cell therapy or CAR T-cell therapy. With the chimeric antigen receptor T-cell therapy, the chance of going to complete remission is more than 50%. So that's a dramatic improvement. And now we have that as a standard of care. That's this bench to bedside collaboration between scientists and physicians and clinicians going back and forth is absolutely necessary to make this treatment more effective and cure more patients.
We'd like to provide the best overall care for patients from soup to nuts, from the moment they get here to 10 years or 20 years after they're transplanted. I always feel relieved that the patient has come to see us because I feel like the patient's in the right place. I would say that we'll provide as good a care as anyone could provide the patient.